Good morning, all. The, yeah, the topic of presentation today is thyroid eye disease. I'm Dr. Bashir Hindatu from National Eye Center, Kaduna. The discussion will be under the following outline: introduction, epidemiology, pathophysiology, disclosing factors of thyroid eye disease, clinical features, classification, investigation, treatment, and conclusion. You may find so many different names that are almost synonymous to the thyroid eye disease that is sometimes abbreviated of well as TED, like Graves' ophthalmopathy, thyroid-associated ophthalmopathy, Graves' ophthalmopathy, and in some German-speaking countries, the blisters. Thyroid eye disease is an autoimmune inflammatory disorder that affects the orbital and periorbital tissue, the thyroid gland, and in rare occasions, the periorbital skin producing myxedema or the digits producing thyroidopathy. It's the most common and most important extrathyroidal manifestation of Graves' disease. In general, thyroid eye disease is seen in patients with Graves' hyperthyroidism, about 80%, but sometimes it may take place in patients that are either euthyroid or have some hyperthyroid autoimmune thyroiditis. Thyroid eye disease is the commonest cause of unilateral and bilateral proptosis in adults. It's usually self-limiting, but may linger for 1 year. The clinical manifestations of thyroid eye disease often lead to morphological facial changes that are disfiguring and may lead to reduction in quality of life. It has an estimated annual incidence of 16 women or 3 men per 100,000 cases. It has a higher preponderance in the females of about 2 to 6 times more common in the females than their male counterparts. Most patients are usually between the ages of 30 to 50 years, and severe disease is mostly commonly seen in patients that are over 50 years, those that are male. Thyroid eye disease is more likely to be seen in patients that are smokers or previously smokers, passive smokers than non-smokers. And the more the cigarettes smoke per day, the more the risk of developing thyroid eye disease. And cessation of smoking has been associated with decreased progression and worsening of the thyroid eye disease. In terms of pathophysiology, thyroid eye disease is an autoimmune antibody-mediated reaction which is believed to be against the thyroid-stimulating hormone receptor. The autoantibody targeted the thyroid follicular cells, and these thyroid follicular cells they shared an antigenic epitomes in the orbital fibroblast. This leads to the circulating T cells infiltrating the orbit and occasionally the pretibial skin. The lymphatic infiltration of the orbital tissue causes release of cytokines like the tumor necrosis factor and interleukin-1. The cytokines, together with some other soluble proteins and immunoglobulins, activate fibroblasts to secrete hyaluronic acid. This glycoaminoglycan increases the content of the orbital tissue of the hyaluronic acid by about 5 times, increasing the tissue osmotic load, causing inhibition of water, swelling of the extraocular muscles, hyperplasia of the adipose tissues, and transformation of some of the pre-adipocyte to adipose tissues, especially in the young. This leads to edema within the orbit, with the congestion and inflammation of the soft tissue that is seen, which is usually mild and severe, the active phase of the disease, which lasts for about a year to 18 months. Thereafter, atrophy, fibrosis, and sclerosis of the extraocular muscles ensues and causing restrictive myopathy, and diplopia. The risk factors for developing thyroid eye disease include hyperthyroidism. 80% of patients with thyroid eye disease have hyperthyroidism, whereas thyroid eye disease is usually the less, about 20% of the other patients that are either thyroid or hypothyroid. Smoking is a very important risk factor for developing of thyroid eye disease. And cessation of smoking has been associated with decreased risk of having thyroid eye disease, with decreasing the progression and worsening of the symptoms of the thyroid eye disease. Female gender. Females are more likely to develop thyroid eye disease as compared to the male counterpart. Then increasing age of onset of any form of thyroid abnormality has an increased risk of patients having thyroid eye disease. Patients that are treated with radioactive iodine for hyperthyroidism, usually studies have shown that compared to their other counterparts that either have surgery or other medical treatments, have more risk of developing thyroid eye disease. Symptoms usually patients present with symptoms that are usually due to ocular exposure, which ranges from dryness, gritty sensation, excessive tearing, photophobia. Extraocular muscles involvement, either during the active phase or the quiescent phase, usually causes the patient to have ocular protrusion, pain with eye movement, restrictive ocular motility. The commonest rectal muscle that is affected in thyroid eye disease is the inferior, followed by the medial rectus, then the superior, and lastly the lateral rectus muscle. Because of the restrictive myopathies, patients may also present with double vision. Eyelid swelling, conjunctival redness, and retroorbital pain are seen in patients with periorbital soft tissue inflammation and congestion. Patients may also complain of visual loss, field loss, and even some color abnormalities when there is an compressive optic neuropathy. Other symptoms that the patient may complain of, or you can find out from the patient, depends on the state of their thyroid function, whether they are hyperthyroid, or they have hyperthyroidism. Those that are hyperthyroid usually complain of palpitations, weight loss despite good appetite, nervousness, excessive sweating, heat intolerance, and tremors, among other things. While those that have hypothyroidism usually have bradycardia, they are drowsy, with poor mentation, muscle cramp, dry skin, cold intolerance, and some menstrual abnormalities. The earliest presentation in patients with thyroid eye disease, the earliest sign elicited in patients with thyroid eye disease are usually the lead signs. They have so many lead signs, but there are a few here, the common ones that I've mentioned, which include the lid retraction. This is a picture of a woman with bilateral thyroid eye disease, and there is an obvious lid retraction. The upper lid usually rests on about 1.5 to 2 millimeters of the upper limbus, but you can see there is even a scleral show here within upper lid retraction. Even the lower lid here is involved, but it's more obvious in the other eye. The lower lid ideally should be just at the inferior limbus, but you can see there is a scleral show between the limbus and the lower lid of this patient. This particular patient has lid refraction in both eyes, but it's more obvious, or it's asymmetrical, it's more obvious in the left eye. You can see, even in the left eye, the lower lid retraction is more. Other signs that the patient can present with include hairy gaze, which is known as the KOCHERS sign. They may have lid edema, which may lead to lid edema, which is the arrow sign, or difficulty in inverting the upper eyelid. They may have lagophthalmos, that's the upper lid lagging behind while patient is trying to look on a down gaze from the primary position of gaze. On the conjunctiva, you can find conjunctival swelling. In severe cases, severe active cases, conjunctival chemosis, superior limbic keratoconjunctivitis, which is a severe, a recurrent conjunctivitis, inflammation of the superior bulba and the upper tarsal conjunctiva. And at times, the cornea may also be involved with some constant erosions. On the cornea, depending on the stage of the disease, patients may have some, just in the early or mild stage, they may have mild corneal erosions. In the moderate to severe form of the disease, you can have corneal thinning, and in the severe sight-threatening exposure keratopathy, corneal ulceration, perforation, and exposure keratopathy. On the globe, I forgot to mention that proptosis is there, which thyroid eye disease is the commonest cause of either unilateral or bilateral proptosis. Adults, then decreased retropulsion can also, which is strabismus, either elevation deficits, abduction, abduction deficits, and some other forms of, as I said, commonly it's the inferior rectus that is initially affected, the medial rectus, followed by the superior rectus, and then the lateral rectus. Patients with thyroid eye disease usually have non-specific pupillary reactions unless if there is a compressive optic neuropathy, where there would be relative apparent pupillary effects. On the fundus, it can be normal depending on the stage. Usually in the mild form, the fundus may be normal, or in compressive optic neuropathy, patients may present with optic swelling, atrophy, lesions, and choroidal folds. The intraocular pressure may be raised either due to restrictive myopathy, where you see a difference of 6 millimeters of mercury or more when the intraocular pressure is taken in the primary position of this, and then with the globe elevated. The raised intraocular pressure may also be due to glaucoma, which can be as a result of the edema of the orbits compressing the scleral venous flow and then causing the intraocular pressure rise. Other findings include thyroid arthropathy, which resembles finger clubbing, pretibial myxedema, goiter, patients with thyroid eye disease. The patient with a severe bilateral 30 millimeter proptosis being prepared for orbital decompression. This is a picture of patient with extraocular motility deficit. You can see the patient is asked to look up. You can see the left eye going up, but the right there is a restriction of the inferior rectus, so the patient cannot look up. This is another extraocular motility, affectation of the medial rectus, fibrosis and contraction of the medial rectus. There are different classifications that has been put forward regarding thyroid eye disease, ranging from the simple classification of type 1 and type 2, where type 1 is usually in which patients have mild inflammation, soft tissue inflammation, and extraocular myopathy. In type 2, patients have severe soft tissue inflammation and restrictive myopathy. We have the no-specs classification, which was put forward by Warners in 1969, which has been widely used for various studies. NOSPEC is a mnemonic with the N standing for no sign or symptoms, O, only signs, usually the lead signs lead to retraction, S, soft tissue swelling, P, proptosis, E, extraocular motility defects, C, corneal exposure, corneal problems, corneal exposure, and then sight loss. This classification has been used for so many years, but then it has its drawback. Patients is not likely to progress from class 1 to 6, and patient can belong to 2 classes at the same time. And then this classification only tells us about the severity of the disease, but it cannot differentiate between an active inflammatory phase and a quiescent phase of the disease. Another classification is the clinical activity score that was put forward by Moritz et al. In 1989. A clinical activity score, actually an activity score that will help us to guide us knowing those that have an active disease and those that should be managed conservatively and those that should need other forms of medical, immunosuppressive, or surgical treatments. There are 7 items in the initial clinical activity score, which include the spontaneous eye pain, visual evoked eye pain, eyelid erythema, eyelid swelling, conjunctival redness, conjunctival swelling, and caruncular swelling, which was later modified to include 3 more items which are assessed. The first 7 items are usually assessed on first follow-up or first time a new patient, where a score of 3 or more indicates that there is an active disease and patient needs treatment. And then a score of less than 3, patients usually have a mild disease and should be measured, should be treated conservatively. The 3 other items are increase in proptosis from baseline of 2 millimeters or more, then increase in extraocular muscle excursion, uniocular extraocular muscle excursion in any direction of more than 8 degrees, and decrease in visual acuity of 1 Snellen line, which were assessed during follow-up. Visa classification was put forward by Dolman and Whitman in 2006, and this is a classification that looks at both the activity of the disease and then the severity to guide the management of these patients. And it's also a mnemonic where V stands for the vision, I inflammation, S strabismus, and A the appearance. It has a total sum of 20 scores. The vision is given 1 point, inflammation 10 points, strabismus and diplopia 6 points, and then the appearance 3 points. The inflammation is usually, that score often is used to assess whether patients need immediate treatment or should be managed conservatively. A score of 4 or less, that means patients need doesn't have an active disease and should be treated conservatively. While a score of 5 or more indicates that patients has an active disease and needs immediate intervention. Then the European Group on Graves of Obliquopathy in 1999 brought out another protocol that assessed both disease activity and severity. The disease activity is assessed through the rating of 10 items from the modified clinical activity score, which include the spontaneous orbital pain, gaze above orbital pain, eyelid swelling, eyelid erythema, conjunctival redness, conjunctival chemosis, inflammation of the caruncle, increase of 2 millimeters in proptosis, decrease in ocular excursion of more than 8 degrees in any direction, and then decrease visual acuity of 1 Snellen line. So a score of It has a total score of 10, just like the clinical activity score, and then a score of 3 or less means that the patient has inactive or mild disease and should be treated conservatively. A score of 3/7, because initially the first 3 items are assessed. The number 8, 9, and 10 are usually assessed during follow-up visits of the patients to see whether there is the disease, whether it's stable or progressive. The EUGOGO class, the European Group on Grapes of Property, also puts on another classification of the disease severity. Because management of thyroid eye disease depends on the degree of the severity of disease, and this is established according to the impact of the disease on the patient's quality of life and then the risk of vision loss. They classify the patients into 3: those with mild disease, when they present with 1 or more of the following features: minor lid retraction of less than 2 millimeters, mild soft tissue involvement, proptosis of less than 3 millimeters, and the transient or nude diplopia, corneal exposure that is responding to lubricants. The moderate to severe group are those that requires immediate steroid or immunosuppressive use in the active phase of the disease, or surgery in the quiescent phase of the disease. And they usually have the following features of lid retraction, more than 2 millimeters, moderate to severe soft tissue involvement, proptosis of more than 3 millimeters, which is above normal for the age and sex of that particular patient. Inconstant or constant. The third group are those that have a sight-threatening thyroid eye disease, which presents, those are the patients that present with compressive optic neuropathy, corneal breakdown due to severe exposure. The diagnosis of thyroid eye disease is mostly clinical, but there are some times that the patients usually there are some times that you may need some other things to be in the preclinical stage of the disease. For those that are euthyroid, some other investigations need to be done, like color vision to assess the optic nerve. And usually some compressive thyroid-associated compressive optic neuropathy can occur in the presence of mild lid retractions and proptosis, which are the earliest signs seen in patients with thyroid eye disease. Central visual field is also important to serve as a baseline to continue monitoring the patients and then to elicit if there is any visual field changes. In patients with thyroid eye disease, they usually present with nerve fiber bundle defects, central scleromas, and inferior altitudinal field defects. Visual evoked potential can also be done. The blood investigations include thyroid function tests, T3, T4, and thyroid stimulating hormone, so that to assess whether this patient are hyperthyroid or hyperthyroid. But then, because this investigation is expensive, some studies are using of serum thyroid stimulating hormone, which can give you an idea whether a patient is hypothyroid or hyperthyroid. For those that have hypothyroidism, their thyroid stimulating hormone level is usually high, while those that have hypothyroidism is low. Full blood count and differential can also be done. Thyroid eye disease, being an autoimmune disease, can coexist with some other form of autoimmune diseases like pernicious anemia. And then one of the differentials of thyroid eye disease being orbital cellulitis, where there is absolute leukocytosis in these patients. Fasting blood sugar can also be done. Then some other tests that can be done include the thyroid stimulating hormone receptor assays, which include the thyroid stimulating immunoglobulin, which shows the ability of the immunoglobulins to bind to the thyroid stimulating hormone receptor, and it's one of the positive biological markers for the development of thyroid eye disease, usually seen in patients with hyperthyroidism. Other assays include the thyroid receptor antibody, thyroid stimulating hormone binding inhibitor immunoglobulins, long-acting thyroid stimulators. All these assays can be done, especially in patients that are thyroid and you are trying to link up the thyroid problem with the thyroid eye disease. Imaging studies can also be done. Ultrasound that is readily available in our clinics and is relatively cheap compared to the other imaging techniques can be done. And then it has an advantage of detecting extraocular muscle enlargement, even in the clinical cases of thyroid eye disease. But CT scan is superior and be used to show the enlargement of the muscle belly of the thyroid rectal muscles, sparing of the tendon, which is usually used to differentiate it from other forms of orbital myositis. The proptosis can also be measured with the CT scan. Then the orbital fat enlargement can also be seen. And CT scan should be done as a baseline for patients that are going for bony orbital decompression. MRI has a superiority of showing orbital apex compression compared to the CT scan. This is a CT scan of patients with thyroid eye disease. You can see the muscles in the right orbit, both the medial and the lateral rectus are large, and then even in the left eye, but it's more obvious in the medial rectus compared to the lateral rectus. Then treatment of patients with thyroid eye disease is usually a multidisciplinary. It requires a multidisciplinary approach involving the ophthalmologist, endocrinologist, and sometimes the ENT surgeons, neurosurgeons, and even the rheumatologists are involved. And the treatment can either be conservative in majority of cases, which fall within the mild or class category, and then medical treatment, radiation, surgery might be employed in cases of severe thyroid orbitopathy with exposure keratopathy with optic nerve compression. The conservative management, the patient with thyroid eye disease can be observed and then they are followed up based on their disease. Patients should be counseled adequately, telling them that this disease is self-limiting. It has a prolonged course. It lasts up to more than a year, up to 3 years. For smokers, cessation of smoking plays a very important role in halting the progression of the disease and in preventing the severe sites loss, the severe complications of the disease. Patients are usually advised to sleep with the head of the bed elevated or to use 2 to 3 pillows to reduce lid edema. Artificial tears can be used during the day and lubricants at night for those that will have dry eye. Then for those that have diplopia in the active stage of the disease, prisms can be used. And then those that were unable to close their eyes while sleeping, they can taper their eyelid. Normalizing thyroid function test also, which is done in conjunction with the endocrinologist, is very important. The mainstay of the medical treatment is use of steroids. Yeah, steroids are believed to have decreased the cytokine activity during the active phase. And patients that have moderate to severe disease during the active phase are those that are usually treated with steroids, and usually a high dose is given either oral with a dose of 60 to 120 milligrams per day until when improvement is noticed that the steroid is tapered, or use of IV methyl prednisolone 1 gram every other day for 3 to 6 cycles in compressive optic neuropathy. Those that are treated with IV steroid, they have less systemic side effects, which include precipitation of gastric ulcer, osteoporosis, and some other patients, like patients that have diabetic, are even contraindicated, have contraindication to use of high dose of this. So other medical treatment, like the use of monoclonal antibodies, are employed, or employed in this, like the rituximab that has been used forever a long period of time. Then there is another newer drug, the cheprotumab, that has been approved by FDA recently, early this year, which shows this drug usually inhibits the insulin growth-like receptor that is linked to be the auto-antigen in the case of thyroid eye disease. Other adjunctive treatments like cyclosporins, octreotide, and IV immunoglobulin are some modalities that are less commonly used in the medical treatment of patients with optic nerve compression. Low-dose radiation of 1,500 to 2,000 watts, fraction over 10 days, is usually indicated for patients that have contraindication to use of steroid, or those that are not responding to steroid, or in combination with the steroid and surgical treatment in some patients with acute optic nerve compression. The radiation is believed to damage orbital fibroblasts, but then it's associated with some other complications, like for cataract formation and activation of retinopathies. For patients, usually surgeries are done when the patient is within the Poisson phase of the disease, unless if there is a compressive optic neuropathy or severe corneal exposure. The sequence of the surgery is very important. The patient, usually the sequence is to do the orbital decompression first, where one wall for orbital decompression can be done, which is the amount of apoptosis to about between 3 to 5 millimeters, or two wall where both the medial and lateral wall can be but it has a tendency of producing diplopia. And then the three walls involving the lateral, the medial wall, and the floor of the orbits can also be done. And then in very severe cases, four-wall orbital decompression can also be done. In some patients where it's noted from the imaging that it's the orbital fat that is more inflamed than compared to the extraocular muscles, orbital fat decompression can also be done. Then the orbital decompression is done first because it can take care of the strabismus and the lid problems. So if there is still, the strabismus surgery is usually done during when the strabismus is has been stable for over 6 months or more. Then usually the rectal muscles, usually it's the inferior and the medial that are commonly affected. The muscles are usually recessed. Then lid lengthening surgeries can also be done in patients that still have lid retraction despite the orbital compression and the strabismus surgery, where in mild cases the molarectomy can be done, or in moderate to severe cases where there is insertion of the levator tendon or the recession of the levator muscle can be done. Blepharoplasty is the last thing to be done, where the orbital fat or at times dacrylplexy can be done in this patient when there is prolapse of the lacrimal gland. In conclusion, thyroid eye disease is a complex, poorly understood inflammatory disease that causes a variety of clinical problems. And management is frustrating for both the physician and the patient because there is no immediate cure for the disease. Treatment modalities also have their own significant side effects and complications. Thank you for your time. These are the study questions.
Thank you, Dr. Bashir, for your presentation.
I would like to invite Dr. Sadiq for moderation. And
that's a very
teacher,
good presentation.
Dr. Allen.
That's a very good presentation, Dr. Bashir. We have among our panelists, Dr. Allen, who is an oculoplastic surgeon, and I'm sure she is with us and would like to say something. So I want to invite her to come and add to what we have been discussing.
Hello, can you hear me?
Yes, ma'am, we can hear you.
Okay, sorry, okay. Sorry, I'm on the, sorry, just in case my network goes off. I'm actually on the highway, so it fluctuates back and forth. Okay. Am I still audible?
Yes, ma'am, we are hearing you. We are with you, ma'am.
Okay.
Right.
Dr. Bashir, thank you very much for that presentation. I was wondering how we're going to count so many things in one. Thyroid is big, it's big, and you were able to put a lot of very salient points. Every sentence had to have something very concise, and you.
Oh, we lost her.
Lost her.
We can take questions.
But Dr. Sadiq, did you get what she's trying to say?
Actually, the voice is cracking, so I'm sure she will join it. I'm sure she will join again. Maybe we can take.
Like I said, because of I'm on the highway. That's why. Am I still audible?
Yes,
yes, ma'am. We are hearing you.
Okay. If I go off, that's it. I just wanted to highlight it's so important to highlight the aspect of assessing inflammation versus activity. You know, because you're going to see the patient at various stages of the disease, and at what point we know, we say we're going to give steroids, we're going to give that, we're going to give this. So it's very important to be able to assess what stage of the disease the patient is at any time when he comes. So you have to know how to assess those parameters. There are two important things to assess. One, disease activity, and two, disease. Wow. Am I still audible?
Yes, yes,
yes, ma'am. We can hear you now.
So you'll be able to to decide. It's important to know, is there mild, moderate, severe disease parameters that you are going to use to say this has mild tissue involvement and diplopia. Now, it's important to know that because the severity actually determines the patient functional capacity or impairment, as it were, to the cosmetic cosmesis of the disease.
I've lost Dr. Ellen.
thing. Okay, at that point, come back the disease. That is normally when you have the thyroid optic neuropathy, you know, and that's very easy to assess because of the optic nerve compression, the changes that you occur, that you see clinically.
Oh, that's neat. We're still having problem with the network.
You have something to say before we get started?
Maybe, Dr. Bashir, you can start attending to some of the questions.
You said?
Maybe you can start attending to some of the questions if there are any before she comes back.
Okay. Now there are no questions.
Like there is no question now.
From what I can get from what Dr. Allen is trying to say, that it's very important to know, based on the severity, which class the patient belongs to. If those that are within the mild form of the disease, moderate to severe, those with, even though the usually those with severe side-threatening disease, it's obvious. So the line, where to draw the line is usually between those that have mild form of the disease and those that have moderate to severe form of the disease. And what you should be monitoring subsequently during follow-up to avoid patients may come to you initially with a mild disease, to avoid pushing the patient into compressive optic neuropathy or exposure keratopathy under your care. So you need to know what to tell your patients to be watching out at. The visual acuity, the color vision, and then the proptosis. The visual acuity, you can even ask your patients to be covering one eye at a time at home. Then the color vision, you should maybe using the television. And these are things that you have to assess at every visit when the patient comes. So I don't know, I hope we get her again to tell us what's the answer.
There is a question there. For a patient who can afford either of CT
Cannot afford. Okay. For a patient that cannot afford that, I think CT scan, you can choose the CT scan because you can use it for the diagnosis and also for the preparation of patients. You'll be able to see the extraocular muscle enlargement and then the optic nerve compression to some extent, even though the MRI gives a better, but at least the CT scan will be able to show you that. And then for patients that are going for surgery, even if it is a orbital fat compression, you need the CT scan to differentiate which one has more, causes more of the globe engorgement, whether it is the orbital fat or the extraocular muscles. And then the bones, whether there is any, and then in the CT scan, you can also be able to see the stretching of the optic nerve, which is a sign of compression of the optic nerve. What is okay? The next question is what is responsible for diplopia and thyroid eye disease, and which classification do you normally take for grading thyroid eye disease? The diplopia in the acute conjunctive phase is caused by the inflammation of the extraocular muscles. And then in the quiescent phase, it is caused by the restriction of the extraocular muscles. Which classification do we take for grading of thyroid eye disease? I think the European group on graves of properties and visa, they are somehow, because those are the visa and then the European group of orbital graves of property, better because they assess both the activity of the disease, in which you'll be able to know which patient has an active disease that requires immediate further investigation and treatment, and those that have a mild disease. And then it further classifies the disease severity. The disease severity is that activity is just telling you that this patient has an active disease. It needs to be further followed up and then treated. While the severity classification will tell you more about these patients are classified more on which treatment to take. Any other question? I hope you can hear me. They can hear me there, sir. Any questions? Okay, these are the study questions for part 1. List 10 differential diagnoses of thyroid eye disease. Then discuss the etiopathogenesis of thyroid eye disease. For part 2, a 50-year-old woman presents with progressive diplopia and visual loss, which starts on the right side and is now progressing to the left side. Findings on examination include glucosis and medication. Discuss your management